Good evening, everyone. My name is Jim, and tonight we have Dr. David Smith with us. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been in practice as a physician for over 30 years. He's an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Orland Park, Oak Lawn, Homewood, and Calumet City. As we go through the presentation, if you think of any questions, please type them into the webinar panel and we will go through them once the presentation is complete.
Hi everyone, my name is David Smith. As Jim said, I'm an orthopedic surgeon for many years, and tonight we're going to talk about some common problems that people have with their knees. And what I want to do is give a framework. When you have a knee problem, what can it be? What things can you do to treat it? And how they're likely to turn out. And I often start out with this first slide. Total knee replacement is not the total answer. I often see patients who've been told they have arthritis, and it's either wait until it's so bad that you need a total knee or you need one now. And sometimes that is the only way to go, but tonight we're going to talk about knee problems as a separate item and what your options are. So the common things that people come in with is either pain, instability. In other words, knee feels too loose. It's not reliable. It's sort of like a friend you can't depend on. Or it's too stiff. You can't bend it. You can't straighten it out. And all those produce problems in everyday life. This is an approach I like to take in all my talks here. And I use it in the office every day. When I see a patient, I feel I've got a responsibility to try and figure out what's wrong so I can answer that first question. The second question is, well, what can they do about it? What are their options? And very seldom is there just one or two options. There's 5 categories, and we'll talk about those. And how can it turn out? I think any of us, if we're going to have something done, whether it's around our house or our car or maybe even our bodies, we want to know what's the chance of success. I often use the example of Sherlock Holmes. He's a fictional character written by Conan Doyle, who was actually a doctor, and he modeled the great detective after a doctor in Scotland who was very good at making diagnosis, figuring things out. And so we're going to try and do that. So to be a detective, what you have to do to solve the mysteries, and in medicine, when a patient comes to me with a problem, the mystery is what's causing it. So you got to gather information. And as an orthopedic surgeon, these are the fundamental things we need to do. We need to sit and listen to you, get your history, so we understand how it's affecting you. Physical exam, despite all the fancy tests we have nowadays, is still one of the major ways we go about answering questions. X-rays are helpful, as well as more advanced tests like ultrasound and MRI, and I'll just kind of go over that briefly. So you got to talk to your doctor, and he's got to listen to you. But he's got to lay hands on you too and see how the knee works. Is it flexible? Is it too loose? Is it too tight? X-rays are important. Oftentimes patients come in and they bring X-rays from an outside facility, and too often they're not weight-bearing, and it really is important to get a weight-bearing film. You can get a knee where the joint space looks pretty good when the person's lying down, but when they stand up and put pressure on it, it's bone on bone. These are the kind of pictures we get with ultrasound. Basically, it's sort of like the submarine thing, I would imagine. It sends out a sound wave, bounces it back. They can focus that, and we get images that'll show us things. Here we're looking at this white line here is actually bone, and then there's a structure called the meniscus. So for some of my patients who can't have MRIs because they have either metal in their body that doesn't allow it, or they've had a pacemaker, ultrasound's a possibility. MRIs, if you're watching all the football playoff games here, you know that every time a guy gets hurt, they're usually talking about getting an MRI the next day. And it shows us the anatomy with great detail. Here we're looking at a knee from the side. This is the patella. In the front of the knee, the femur. This little gray area here is actually the cartilage, and the black thing here is the meniscus. And we'll be talking about each one of those as we go through the anatomy of the knee. And this is a book that I read some years ago, and I think anyone's interested in the science of medicine and the importance of anatomy is you might want to look at. It's called The Knife Man. It's written by a fellow named John Hunter, who was a famous anatomist who is considered one of the fathers of modern surgery, because he understood the structure of the joint. And that's what we're going to try and do tonight, is show you some of the structures that can cause problems. So if you look at this picture, a simplified view of the anatomy of the knee, there's 4 bones we're looking at: the kneecap, we call it the patella, the thigh bone, the femur, the tibia or shin bone, and then the fibula. So what are some of the important structures here that can cause problems? Here's one of the more common ones. This little pad here called the meniscus. You'll see one on the outside, the little toe side of your knee we call lateral. The big toe side we call medial. So there's one pad on each side. The ligaments, there's 4 major ligaments. You see the ones along the side, they're called collateral ligaments. And there's 2 cross ligaments called cruciates. So injuries to these ligaments can cause problems early on and also later on in life. I've seen people come in my office who had an injury to their ACL, this anterior cruciate ligament, when they were in high school, did fairly well for a number of years, then eventually it led to other problems. So those are the structures that we evaluate, but this white shiny material here is really the key to a healthy joint, and that's articular cartilage. In the same way, if you looked at a set of tires, the first thing you're going to do to judge that tire is see how much tread is on it. And this is the actual tread that coats the end of each bone and allows bones to run over each other without having pain. It distributes the pressure across the bones. So if we're going to be Sherlock and we're looking for the bad guy that's causing our knee pain, what are the suspects? Well, we've looked at the anatomy there, so we know that a meniscus is an important structure, and what can happen? It can tear. And we see tears in 2 different populations. One, I see the young people who've been playing a sport, and 2, I see the older people, which now I fit into that category, that just get a wear and tear type tear, and those can be painful as well. Ligament tears we were talking about, and again, it's important. Sometimes it's a fresh tear, but many times it's someone had an injury some years ago. It resulted in too much looseness of the knee. And in the same way, if you're driving down the street, we've all seen the case where you see someone's car and you notice the wheel just seems like it's not running true, and you figure that tire is going to wear out. And the same is true of a human knee. If you get a ligament injury and it persists, you never get the stability back, then very likely you're going to develop a wear process that, instead of calling it wear, in medicine we call it arthritis. And we'll be talking a lot about this category. Loose bodies. This is one of the byproducts of arthritis, is the cartilage wears. It sometimes comes loose, either just the cartilage itself and sometimes associated with a piece of bone. We used to call these joint mice because nowadays when we scope a knee and look into the knee, we remove these loose bodies, and sometimes you essentially are chasing them around like a mouse to get them. But they can catch in the joint and they can cause pain. And then finally is synovitis. You think, well, what is that? Anytime you see this little itis, we're talking about inflammation. And the synovium is the lining of the joint. If you were sitting in a room and the wallpaper of the knee is really synovium, and it secretes fluid, which is the oil that allows us to lubricate and provide nutrition to the cartilage. It lowers the friction inside the joint. So some of the things that we're looking for, every time I'm in the office and I see someone's come in for their knee, I'm thinking, do they have a tear of their meniscus? Have they had a ligament injury? Do they have arthritis already? With this arthritis, do they have loose bodies? And how much inflammation do they have in the joint? All these things are important. So again, what is arthritis? We sometimes refer to the most common type, wear and tear, as degenerative arthritis or osteoarthritis. So you hear a lot of different names, but basically it refers to loss of cartilage from the joint. Now many times that cartilage loss is associated with inflammation. And that's an important thing, I think, before we start talking very much about treatment, because anytime you get a treatment for your knee, it's usually one of these factors we're trying to treat: the inflammation itself or the mechanical problem. And many times early on, the pain in your knee is caused primarily by inflammation. It's irritated. It's almost like getting something in your eye and it's producing more tears. The old expression, water on the knee, comes about when that synovium, that wallpaper inside the knee, gets inflamed and it produces too much fluid. Now, mechanical problems as time goes on, if you do have arthritis, the cartilage starts to wear out. You start to apply excessive loads to the bone in the knee, and these bones start to undergo changes, and they themselves cause pain. So while early on, some treatment for inflammation may be very successful, later on, as the mechanical problem becomes a bigger part, it may be less effective. This is something from an anatomy slide. It just shows the lining of the knee. Here in the front of the knee, we see the kneecap. I know it's probably a little confusing, but it's like having on a pair of slacks. They can be just right, they can be too loose, or they can be too tight. And oftentimes in arthritis, that capsule gets very fibrotic, and it gets too loose, and too tight, and that can create a problem even when you successfully treat the arthritis if you have a tight capsule. And this is one of the things I want to keep emphasizing. It's so important to keep that capsule loose and pliable. This little diagram I have here, and it tries to put everything together. On the left side, as you look at your screen, you see what the structures diagrammatically anyway of a knee. We see the bone, the yellow part here. You see the articular cartilage, the white part, the tread on the tires we were talking about. The capsule that we just showed, you can see that on the outside, the light green. And then on the lining, that wallpaper I talked about, the synovium that secretes the fluid that fills the synovial cavity. And then it comes down to bone meeting bone. What happens in arthritis? Well, a variety of things go on. One, the joint cartilage starts to break down. You start to lose cartilage. Some of those loose fragments get embedded in the lining of the wallpaper, the synovium. You get inflammation. The capsule becomes chronically inflamed. It thickens. And so now you don't have a soft, pliable capsule. It's thickened. You're overproducing fluid. The knee becomes stiff. And then you're walking with your knee in less than an ideal mechanical situation where you're overloading the bone. And the bone responds to the pressures placed on it. And we see this thing called sclerosis. Actually, it's a hardening of the bone. When we do joint replacements, this bone can be extremely hard, and that produces a painful situation where you're transferring very high pressures into the bone. We see other changes. Sometimes if a doctor's looking at your x-rays, he may say, oh, you have a bone spur, or what we call osteophyte, and you see this little outgrowth here that comes about from the bone reacting to those abnormal pressures. They oftentimes will refer to cyst, and I know that frightens some people because you think of cancerous cyst. This is not cancer, it's an arthritic condition. And it's little cracks that form in the bone, joint fluid goes in there, and it forms these holes. So when a doctor looks at an x-ray, he looks for those things. He looks for bone spurs. He looks for this white, dense area of sclerosis. He looks for cyst underneath the bone. So this is a little summary of the structures in the knee. The cartilage doesn't have any pain fibers, so that doesn't produce the pain. The synovium has some, but it responds to baroreceptors, which really is pressure. When people talk about they can predict the weather, well, there is some scientific support for that with changes in barometric pressure, when you see the highs and lows on the weather map, and when that's changing rapidly, your knee may be able to help you predict the weather a bit. Ligaments have these things called proprioceptors, and basically they're to help you, your brain functions and telling the muscles how to respond by knowing where your joint is positioned. That's why very athletic people have a good sense of their body. Like Michael Jordan can go up in the air and make all sorts of moves, and it's because he was very gifted in that sense. Some people with diabetes lose some of that reception, and that can produce some problems. However, the bone is one of the sometimes neglected generators of pain. And a lot of things that we talk about, loss of cartilage reduces high pressure in the bone. Loss of stability puts stresses on the bone that cause pain. So one of the things we'll mention a little bit here is this thing called bone marrow edema, and this is only seen on MRI. We really can't see that on an x-ray. And that's why it's so important, I think, for a lot of patients, if you've got significant problems with your knee, to get an MRI of your knee. If the simple treatments don't work initially, I think that MRI can be very helpful in predicting what's causing the problem. And there's just some studies that have supported that. We know if we inject a lidocaine, which is a numbing medicine, into a joint, it doesn't relieve all the pain. The reason is the lidocaine only goes to the structures inside the joint. It doesn't go to the underlying bone. There are some newer things coming along to treat that, and it hasn't been out that long, but it's this thing called subchondroplasty, where we inject a bone healing material into these areas where the bone's overloaded, and that can be helpful in the early stages of osteoarthritis. So, the common form of osteoarthritis, wear and tear. You'll hear the expression OA or osteoarthritis. And we wanted to make a distinction between that and rheumatoid arthritis, which we're not really emphasizing that much tonight. I mean, rheumatoid arthritis fits into that category of inflammatory types of arthritis. In my 30 years of orthopedics, I've seen more progress in the medical treatment of inflammatory arthritis, psoriatic arthritis, rheumatoid arthritis, than I have in any other area. And osteoarthritis, the one we're more likely to get, the medical treatments have not been as remarkable as they have in that other area. But tonight we're talking about osteoarthritis, the most common type. We were talking about bone spurs and the joint overgrowing and then lining producing problems, cartilage being worn out. But it's important to keep in mind. That's why, as we started out, we said there were several things the doctor needed to do to make a diagnosis, and certainly history, physical examination, x-rays, but they don't tell the entire picture. You can look at someone's knee. They've done studies where they've had people who had no knee pain come in and get x-rays. And certainly for people in their 50s and 60s, we start to see arthritic changes. And for some of those people, they have advanced arthritis, but really no pain. Then you have other people who have a lot of pain in their knee, but they really don't have what you determine as arthritis, at least on an x-ray. Now, further investigation with the MRI and even with arthroscopy, where we look in the joint, can show us subtle changes that may be producing that pain. And then finally, you can have pain and arthritis, but it may be a non-arthritic pain. In other words, I've seen a lot of patients who had pain about the knee, and they did have some arthritis in their knee, but they also had an arthritic hip, or they had problems with their back that referred pain into that area. So just getting an x-ray and seeing you have arthritis doesn't always explain everything. You need to correlate it with your history, your physical exam. So we're coming to so the first question was, well, what's the problem? What's wrong? What can we do? What can we do about it is the next question. And Shakespeare had something to say about everything, and he said there are more things in heaven and earth than dreamt in our philosophy. And as doctors, we have to remember that. There's more than one treatment many times. And my grandmother had a simple way to say it. There's more than one way to skin a cat. And the approach I use is what I call this 5 fingers methodology. And it's just a little reminder that there's 5 major categories of treatment that we do in orthopedics: physical therapy, medications, injections, bracing, and surgery. You might say, well, how do these fit in? How's therapy? How's medications? How's injections, bracing, surgery? How does that help an arthritic joint? And when should I do physical therapy, and when should I do surgery? And of course, these are complex things, and we want to just give you little guidelines so you can think about them, but you need to discuss it with your doctor. So physical therapy, to me, that's the baseline for any arthritic joint. A stiff knee is a painful knee. It's very important that a knee have good flexibility. In other words, your ability to straighten the knee and to bend the knee adequately for everyday activities. You also need good muscle control of that joint. We have a thing in our physical therapy program, I call it the Knee Arthritis School, which teaches patients self-management techniques for their knee. And even people with very advanced arthritis can benefit from that. It's the sort of thing that we follow this Shelbourne program. Dr. Shelbourne's a well-known knee surgeon who came up with these principles that first we would start on extension. If a person walks with their knee bent, if you played a little game where you walked around and with your knees flexed, it won't be very long before you'll ask, can I straighten my knee out now? But some patients can't straighten their knee out, and they walk with the knee flexed. It's what we call a flexion contracture. So it's really important to get rid of that, and it's really important to prevent it. If you're having a problem with your knee and you're having problems straightening it out, you need to get in to see a therapist and get a program going, because that can help diminish some of the pain and put your knee in a better position when you're walking. Flexion is important for everyday life, getting in and out of chairs. If you can't flex your knee, it's very difficult. You're going to have to push yourself up with your arms. And then finally, strength. One of the things arthritis does, as well as causing stiffness, it does cause what we call reflex inhibition, which in simple terms mean the knee gets weak, and you need to make a special effort to maintain the strength. And study after study has shown that by improving the strength of the major muscle in the front of your thigh, called your quadriceps, and the flexion muscles in the back of your knee, the hamstrings, if you can strengthen those two areas, it's very helpful for arthritic joints, even of an advanced degree. Therapists also work on your gait posture. A lot of us tend to slump a little bit, and we transfer weight to our bones in less than biomechanically optimal way, and this is where therapists can help you. They also are able to look over your entire joint alignment. Some of the braces we'll be talking about are directly put on the knee, but many can be put on the foot and the ankle to improve your stance alignment. Medications. Probably all of us have either had Motrin, Advil, or Aleve at some time in our lives, or aspirin. These are anti-inflammatories. They fit into a group called NSAIDs, non-steroidal anti-inflammatories. What's that mean? Well, it means it's not cortisone. It just means that it's a non-steroid, and it's an anti-inflammatory. So that synovium, that wallpaper we were talking about for the knee, this medicine works to diminish that, because the inflammation does cause pain. But all these medications have the potential for causing problems in some patients. If you have ulcers, if you have diabetes, if you have kidney problems, you need to check with your internist. The fact that you go to the drugstore and get it without a prescription doesn't mean it's 100% safe. And I do get patients coming in, they're taking much larger doses than they should be. There's probably over 100 different prescription ones. This little picture here is one called Celebrex. It's one of the newer ones. It's in a little different group of anti-inflammatories to have less GI side effects, but it's just something you'd have to discuss with your physician. Now, there are some newer things coming along. This Voltaren gel, we'll probably see more of these. Voltaren's been around for a long time, diclofenac, as a pill, but now you can get it as a gel, and for some structures around the knee that are inflamed, you can rub this on, and it works. It's not like the other aromatic type ones where you just rub it on and it causes a cooling menthol effect, but this actually gets medication into the tissue. And it avoids the systemic things. When you think about it, you take a pill, you want it to go to your knee, and it goes to all the tissues in your body. So this is a hopeful new approach. Glucosamine, chondroitin sulfate. You get a lot of questions. This sort of fits into that health food category. I don't see any harm in it. It's been discussed quite a bit. It doesn't regrow cartilage. I know sometimes they give you the idea that it's going to regrow your cartilage. It doesn't do that. It's been studied a lot. It seems to have a mild anti-inflammatory effect. Doesn't seem to have a lot of side effects other than you could possibly choke to death on it. The pills are pretty big. What I found, I talked to an internist friend who said, take it with applesauce, and it makes it easier to swallow. Actually, really large pills, swallowing them with water is not the ideal way to do it. The applesauce kind of invokes this swallowing mechanism, makes it simpler. So it's another possibility. It's not a non-steroidal anti-inflammatory, but it has some anti-inflammatory effects. So those are a couple medicine approaches. Injections. This 3 categories. Cortisone. I could spend the whole night talking about cortisone. I get asked so many questions. It's like anything else. Cortisone, I think, is an amazing medication that can really help a lot of people manage their arthritis. But it's like water. You know, I often say to patients who are so scared of cortisone, it exists in your body. You would actually die without cortisone in your body. But like water, a glass of water is not going to harm you. Falling in the middle of Lake Michigan will. So when you hear about these athletes that had injections for every football game they played in, destroyed their ligaments, I don't think it was necessarily the cortisone, but it's something to discuss with your physician. It's a good option. I really regret it when patients just eliminate this because they have some misinformation about it. It at least needs to be given some serious consideration. Viscosupplementation, what is that? A study was done some years ago in Europe looking at joint fluid, sort of the oil in the engine of the knee, and found out it was low or deficient in a certain chemical called hyaluronate. And they found a way to extract it originally out of chickens and purify it and inject it. And we've been doing this for about 15 years, and it certainly helps a significant number of patients. If I were just to kind of guess what I've seen over those 15 years, I'd say that for a lot of patients with moderate to even severe arthritis, probably about 2 out of 3 people will benefit. It's usually 1 shot a week for 3 weeks. There's different protocols. There's some medications that involve 5, and there's a few newer ones coming out that are just one single injection. PRP, platelet-rich plasma, again, something you hear about for the athletes. Let me just flip through a few of these. So cortisone, because the professional athletes had problems, doesn't necessarily mean we're all going to have the same problems with using cortisone. Suparts, Synvisc, Orthovisc, these are some of the brands you'll hear for the viscosupplementation, and found it effective. It doesn't cure arthritis. It doesn't cushion the joint in the sense of if you took an x-ray after getting the injections, the space between your bones is going to be the same. So there's a lot of misunderstanding about it, but it does help a lot of patients. PRP, platelet-rich plasma. The blood has different components. There's red blood cells that carry oxygen, white blood cells that fight infection, and then platelets that are involved in wound healing and clot formation. And some of the thought was that inside the platelet cells, there's chemicals that can facilitate healing. And they thought, well, if cartilage is damaged, maybe we can use these growth factors and other bioactive proteins and stimulate healing. So what they do is take a blood sample, centrifuge it, and separate out the platelets, and then inject it into the joint. Medicare doesn't pay for it. I don't know of any insurance company that pays for it. I do them in the office when patients want to give it a try. There really isn't real solid evidence to its effectiveness. I've had some patients who felt it helped them. There is some theoretical arguments saying that it could be of some benefit. If you're ever interested into it, there's a whole alphabet soup of different growth factors that it uses to stimulate the knee, almost like caffeine for our brain when we're getting tired. So those are your 3 choices for injections. Bracing, as we showed before with the physical therapist, you can start at the foot. Many times shoe wear, actually orthotics. And I usually encourage patients to start with the simple things you get at the grocery store. Try those first. Look at how you wear your shoes and see if you can improve it. If your ankle and foot don't meet the ground at the correct angle, it puts additional stresses on your knee. It can aggravate an arthritic joint. Then there are these heavier braces that I've used for a lot of the fellows in the trades. Probably a little more adaptable to a man's leg, but I certainly have female patients who benefit from them. And the idea is that if you have a knee where you're wearing more on one side of the knee than the other, which is a fairly common pattern, you'll see people that are either bow-legged or knock-kneed, and when that is from arthritis, these more expensive braces can help. Again, I often recommend to patients, try the simple elastic ones you get at the grocery store, and then you can work your way through some of the ones your doctor might suggest to you. Surgery. Now there's a wide category. First starting with arthroscopy, I think it's been very helpful for a lot of patients. When you look at in the perspective of arthritis, for a lot of people, they may require some type of treatment over long periods before it ever gets to a point where they would need a knee replacement. And arthroscopy can certainly help when pills and shots and braces and therapy haven't completely done the job. What do we do? A lot of folks with arthritis get wear and tear of their meniscus, that pad we talked about, and that can cause some problems. The lining of the joint can overgrow. We can partially remove some of that synovium, that lining, and that helps a little bit with the fluid production. Debridement, those particles that come loose in the joint can catch and cause irritation. And then there's some procedures, microfracture and this thing called ACI and mosaicplasty to help with cartilage restoration. This is more applies to patients under the age of 50 for the most part. And then the newer thing coming along we talked about briefly, where you inject this calcium phosphate into the bone to try and strengthen bone where it's been overloaded from an arthritic joint with deficient cartilage. And then you go into these corrective osteotomies, which essentially what you're doing is sort of breaking the bone and realigning it, and this was more popular in the late 70s. But as joint replacements became more reliable, more successful, we just don't see as much of that. It certainly can. It's an option that needs to be at least considered. And for some people, that probably, if you're in the younger age group and you have a more demanding type of job or sport and you're willing to try and do the rehab, I think it can be very helpful. Joint replacement, we'll discuss that at greater length here in a little bit. So what's this tire laying out here supposed to represent? Well, when I scope a knee, we sometimes will find loose fragments within the joint, and I compare that to this tire tread that wears off a truck tire. Scoping really is just making these tiny little 3 to 4 millimeter, about a 1/4 inch hole in the knee, and we go in there and put a scope in, and with the modern videos we can look around like we're on a vacation, and we can check the meniscus, check the ligaments, we can clean the joint out, smooth off the surfaces. It's a pretty good track record. It's controversial as to whether or not it's appropriate to use it for arthritis, but I think there's plenty of studies that support it can be helpful, particularly in patients with symptomatic mechanical problems such as a torn meniscus. This was a study that was one of our journals a while back, looked at knees 10 years after having a scope for arthritis, and they were able to find that 2/3 of them after 10 years had still not had a knee replacement. About 60-some% of them had no additional surgery, but 1/3 did go on within 7 years and have a knee replacement. So it's certainly worth considering. There's a variety of papers that show good to excellent results. Now these are papers on patients done 2 to 4 years out. There's some well-known athletes that have had their knees scoped multiple times, and you might say, well, what's the message there? You know, I'm not a professional athlete, but I think what it says is that by scoping these knees and cleaning them up, people that are beginning to get arthritic problems can return to more active lives for short periods of time. 2 to 4 years, certainly worth considering that option. What do we actually do? This is looking down on top of the shin bone or tibia, and this is the meniscus. It tears. Those tears can catch in the joint, and we clean that out. The synovium, if it overgrows, that lining, that wallpaper I talked about, we can clean that up a little bit, even in rheumatoid arthritis as well as osteoarthritis. Removing those loose fragments. These are some fragments I took out many years ago out of a patient's knee, and we often see that, and you might say, well, where did that come from? And if you look at the end of the bone of the femur, you can see here, looks like a pothole. Well, those fragments came loose and they irritate the joint. This is a picture from a scope. It shows what beautiful normal cartilage looks like, the smooth, glistening surface. Microfracture. This is something where we actually drill into the bone, and you might say, well, what does that do? Well, what we're trying to do is allow that there are cells called stem cells that live deep in the bone marrow, and they can, in some cases, stimulate regrowth of what's called fibrocartilage, which is a patch that goes over that area. It's been done for many years, and it's successful in properly selected patients. ACI, I went to Sweden in the 1990s to learn how to do this. We take cells from one part of the knee, send them to a lab in Boston, they regrow it, and then we sew these patches over the area. Again, when you hear about this, a lot of people will hear this on the news media and they'll think, oh, well, that's what I want. You know, I want to regrow my cartilage. And that sounds good, but it really is only effective in younger patients who have most likely post-traumatic defects where they've damaged, but the rest of the knee looks good. Someone heard once at a meeting say we should tell patients we can fix potholes, but we can't resurface the entire road. And what that means is a small area of cartilage damage, we can help you. The entire joint thus far we're not able to do. Mosaic plasty, I also can refer to this like the hair transplant for the knee. You take cartilage cells with bone from one part of the knee and you plug it into another part. And again, it's an option that for some patients with very localized cartilage loss can be helped. So now we get into metal and plastic, partial knee replacements, total knee replacements. What's that mean? What's it look like? I often tell patients, when I look into a knee and a scope, I think of it as a 3-room apartment. There's the 2 weight-bearing parts where your femur meets your tibia. The big toe side we call medial, the outside little toe side we call lateral. There's the patellofemoral joint, which is really engaged when you get out of a chair, when you go up and down stairs. That's when your patella is really getting a lot of pressure on it. When you're walking on normal flat ground, it doesn't get as much. So this is sort of where the rubber meets the road, medial and lateral. So arthritis tends to be a segmental disease. This is a classification system. This is very early, we're looking at joint space here, less than 50%. This is the sort of knee you're going to be scoping or injecting and treating, not with an implant. When you get into stage 2 and 3 all-back classification, here we're talking candidates for unicompartmental. The largest percentage of arthritis when I see patients coming in is usually only on the medial side early on. And so these patients have an option of being treated with the partial knee replacement. I'll show you a picture of one here in a little bit. Now when it gets this far along, there's nothing but a total. So stage 1, non-implant, in other words, not a partial, not a complete. Stages 2 and 3, you can think about a uni, which is a partial knee replacement. And certainly if I had arthritis in my knee, I would, if at all possible, I'd want to try the uni. And of course, if it gets to this stage, the only choice you really have in terms of an implant is the total. What's nice about it, the rehab is much easier. It's not exactly like an arthroscope. It takes longer. I saw a lady today I did a couple months ago and very pleased. And it's not just because I did it. I think any of the doctors that do partial knee replacements find that the happiest patients they have, the quickest recovery, is the partial knee replacements. It addresses the ligament imbalance. You fill that gap again, and that helps restore some stability, helps slow progression of the arthritis. You take care of that sclerotic or hardened bone that's under the area of arthritis. It's a segmental treatment for a segmental disease. If you got 4 tires in your car and only one's got some problem, you replace that one. And it preserves the knee. It's good for the very young patient, and it's good for the older patient. It's the longevity of these unis has really improved. And when you look here, here's a study that was done, and they looked at arthritis and the distribution, these little Venn diagrams, these circles. What's this circle mean? That 166 patients only had arthritis in the medial compartment, 21 only in the lateral, 130 only in the patellofemoral. So the majority of the patients had it only in one of the compartments. So you might think, well, why do the entire knee? And that's a philosophy some of us have. So this again shows a common pattern. Arthritis on the big toe side. Here shows the implants. It's metal with a poly or plastic liner. You can see here it's curved to fit, and then there's a base plate. Put it in. And early on, the question was, how long will these last? And these are some of the studies, 21 years, 86%. Berger, his study, I think now is out to 15, 16, almost 20 years, and high 90s, 15 years. So you see survivals, 20 years, close to 90-some%. And there was even one study, forgetting where this one was done, but this is something that I've seen, which is patient rating of the result. And 71% of unis said it was excellent. Now the good is, we sometimes lump excellent and good together. When you think excellent, that's someone who's really quite pleased. Only about 50% of total knee patients said that. And the survival in this one study was Newman, had a 90% survival at 15 years, and his total knees didn't last as long. So usually they're pretty close. And usually we're thought that the totals are probably going to last a little longer, but with the newer alignment techniques, seems to be holding up. Total joint replacement, is that just one type of thing? Well, no, there's really at least three types. There's a cruciate retaining, there's posterior stabilized, and there's constrained. What's this mean? Of the four major ligaments in this CR knee, which I try and do in most of my patients who need total knees, is we're preserving all the ligaments except for the anterior cruciate. This one, the posterior cruciate ligament is taken out, and I prefer to do this. And it's discussed at meetings, and good results can be had with both CR and PS knees. But it's just another factor for you to be aware of, and if you're looking at having a total knee, you might even ask your surgeon which he does. And you want to at least understand what your choices are. And of course, when we get people that really have extreme arthritic wear, we get into these more constrained devices. There's two things, too early and too late, like most things in life. If you wait too late, you might go from a situation where you could get by with a partial knee, and now you've moved to that all-back, more advanced stage, and the only choice you have then is total. If you do it too early, I've seen patients, when you look at results of total knees, a lot of the studies have shown about an 80% satisfaction rate. And people are looking at that. And one of the things is that some patients may have gone too quickly to that treatment, and they weren't as pleased as someone who had more advanced arthritis and could see a more significant difference. And then there's the patient who waits too late, and then they have less ligamentous stability, they've really deformed the bone, and you get in more of a salvage situation, and it's going to compromise your outcome. Yeah, like we were showing that capsule before, it gets too tight, it gets too fibrotic. So what are some of the things about knee replacement? Well, the alignment things have really made a big difference. This is a computer system I've used for a number of years. They keep modifying it, but it's been a great aid. It allows us not to put these rods up the femur. It allows us intraoperatively to make decisions about the alignment and to make adjustments, because what we're balancing two things. One is the bone alignment, and the other is the soft tissue tightness and the structures, and we have to work with what we have. It's not like working on a car where you can go out and get a new suspension. We have to work with the ligaments that exist. But this is like a GPS system for your knee. It's been very helpful. Ingalls bought this system for me several years ago, and it has been a great help, because alignment is one of the key things to getting a good knee replacement. What are the other factors? Basically, it's nice in Chicago because you've got so many places you can go where they do high volume joint centers, and study after study has shown you want to go to someone who does a lot of it, both the hospital and the doctor. Ingalls is such a place. This is part of our joint center. We've got nice private rooms. We like to keep our patients. No one with infections is allowed on the floor, and it really is has a very low infection rate. So that's our rooms there. So I think everybody remember, at least I do, I always like the cowboy things. Warren Bond, remember, he had a whole show called Wagon Train, and it was about taking people out west, and his job was to get them there. And in a way, that's your surgeon's job. You have to decide what you want and find a surgeon or a physician who can help you meet your goals. Now, we can't make everything right, but you need to really let your doctor know what your expectations are. I think a lot of the studies have shown the reason people weren't satisfied is they didn't have a good understanding of what could be accomplished with the treatment. And I think that's we go back to our 3 questions. What's wrong? We've talked a lot about that. What you can do about it, we just finished those 5 categories. How's it going to turn out? That's the next question you need to discuss and sort of answer for, know where you want to go. And if your expectations exceed what that treatment can provide, then maybe you ought to avoid it. So that kind of is a summary of my approach toward dealing with knees. Hopefully it answers some of your questions.
Well, thank you very much. As we mentioned at the beginning of the podcast, we would be answering questions. We don't have any so far, but we'll give it a minute or two. If you have questions, in the control panel, there's a section for questions. Just type them in, and we'll ask Dr. Smith one at a time.